Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam, or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is a question series all about gram-positive bacteria.
Let's do a question. A 65-year-old woman with a history of multiple abdominal surgeries presents to the hospital with fever, abdominal pain, and urinary symptoms. Her urine culture grows gram-positive cocci in chain that are resistant to penicillin and have a high level resistant to aminoglycosides. Which of the following is the most likely causative organism? A. Staphylococcus aureus, B. Streptococcus pyogenes, C. Enterococcus faecalis, D. Streptococcus pneumonia, E. Escherichia coli. If you recall from our talk today, the most likely cause in here is going to be option C, or Enterococcus faecalis, because this is a lady who has coming in with abdominal symptoms and also urinary symptoms, and she's had multiple abdominal surgeries previously. Her urine culture has grown gram-positive cocci in chain that are resistant to penicillin and have a high level of resistance to aminoglycoside. So hopefully that should ring alarm bell for you that they are talking about an Enterococcus. And the only Enterococcus option that they have given you in here is option C. Just very briefly, Staph aureus, remember this is gram-positive cocci that is commonly associated with skin infection as well as endocarditis and quite a few other infections. If you want a full recap of Staph aureus, please click here. Streptococcus pyogenes are very commonly associated with pharyngitis. If you would like a review of Streptococcus pyogenes, please click here. Streptococcus pneumonia is the commonest cause of community-acquired pneumonia, which is the commonest reason for adult inpatient hospitalization in the UK. And if you like a recap of that, please click here.
So let's now try a question. An 18-year-old male presents to the emergency department with a 48-hour history of a sore throat, fever, and hoarseness of voice. On examination, he appears unwell, with a barking cough and stridor. Inspection of the throat reveals a thick greyish-white membrane covering the tonsils and pharynx. He did not receive some of his vaccinations as a child. Which of the following is the most appropriate initial management for this patient? So these are our options. Firstly, administer a broad-spectrum antibiotic and schedule for urgent tonsillectomy. Second, immediate administration of diphtheria antitoxin and start benzyl penicillin. C. Provide symptomatic treatment with paracetamol and observe for 24 hours. D. Initiate oral corticosteroids. Or E. Vaccination with diphtheria, tetanus and pertussis, or the DTP vaccine. So in this case, the correct answer, as you will recall from this presentation, is immediate administration of diphtheria antitoxin, because this is a probable or possibly even confirmed case at this point, and start benzyl penicillin. So let's try a question. A 45-year-old male farmer presents to the emergency department with a 2-day history of fever, a painful swollen area on his forearm, and a black eschar surrounding the edematous skin. He reports handling sick livestock without protective gloves a week ago. Which of the following is the most appropriate initial management for this patient? So our options are immediate initiation of IV penicillin, surgical debridement of the eschar, administration of tetanus booster, oral clarithromycin, or application of topical steroids to the lesion. And you will recall from what we previously discussed that in these patients, urgent antibiotics is crucial, and usually this is penicillin. Clarithromycin would not be effective for anthrax. So let's try a question. What is the most appropriate initial management for a patient presenting with mild symptoms of Bacillus cereus food poisoning? So our options are antibiotic therapy, supportive care, antitoxin administration, surgical intervention, or antiviral medication. So the answer in this case is supportive care, usually with hydration and electrolyte therapy. This condition does not usually require antibiotics. So now let's try a question. A pregnant woman at 28 weeks gestation presents with a fever and flu-like symptoms. Blood cultures are drawn and initial microscopy reveals gram-positive rods. Which of the following is the most appropriate next step in management given the suspicion of listeriosis? So our options are as follows. Await culture confirmation before initiating treatment, start empirical treatment with ampicillin, administer a broad-spectrum cephalosporin, prescribe oral azithromycin, or initiate treatment with vancomycin. Now, you'll remember from the presentation that it's really important to start treatment with ampicillin, and it's also important to consider in the MRCP exam as well which particular drugs are safe in pregnancy. So through that, you can automatically eliminate some answers even if you didn't know the answer to this particular question. But as it happens, the treatment of Listeria in pregnancy would involve ampicillin.
Okay, let's do a question. A 55-year-old man with a past medical history of kidney transplant is diagnosed with Nocardia asteroides pulmonary infection. He is currently on cyclosporin and prednisolone. Which antibiotic regimen should be initiated? The options are A. Intravenous vancomycin, B. Oral doxycycline, C. Intravenous amphotericin B, D. Trimethoprim sulfamethoxazole, E. Intravenous ceftriaxone. If you guys recall, the first option to treat Nocardia species, which is the case in here in an immunosuppressed patient due to taking immunosuppressive medications for their kidney transplant, is cotrimoxazole. And cotrimoxazole is option D, which is trimethoprim and sulfamethoxazole. Let's do some questions. So, a 40-year-old man presents to the emergency department with severe pain, swelling, and dark blistering over the right forearm following a deep laceration he received while cleaning an old lawnmower. He has a fever of 38.7 and his blood pressure is 90/50. The affected area emits a foul smell and crepitus is noticed on palpation. His heart rate is 120. The most likely diagnosis is gas gangrene. Which of the following is the most appropriate initial management of this patient? A. High-dose intravenous penicillin G. B. Oral metronidazole. C. Intravenous fluid resuscitation and high-dose intravenous penicillin G. D. Immediate surgical debridement and intravenous vancomycin. E. Intravenous fluid, surgical debridement and high-dose intravenous penicillin G. So going back to the scenario, you will realize that this is a patient that is showing signs and symptoms consistent with septic shock, and that is having a high heart rate and associated low blood pressure. It's been easy on you by giving you the diagnosis that this is a gas gangrene, and it's pretty much just asking about the immediate management. You should all pick the option for intravenous fluid resuscitation given that this is a septic patient. And if you recall from our slides earlier, you would realize that a surgical gas gangrene is a surgical emergency needing a surgical debridement. And intravenous penicillin G is the antibiotic of choice in the meantime until the necrotic tissue is excised. Let's do some questions. Question 1. A 30-year-old construction worker presented to the emergency department with difficulty opening his mouth and stiffness in his jaw and neck. 2 weeks after sustaining a minor laceration on his leg at a construction site. He has not received any immunization since childhood. Over the next few hours, he develops a spasm in his facial muscles and opisthotonus. Which of the following best explains the mechanism of the symptoms? A. Inhibition of acetylcholine release at the neuromuscular junction. B. Activation of inhibitory glycine receptors in the spinal cord. C. Blockade of inhibitory neurotransmitter release in the central nervous system. D. Direct toxin-mediated neuronal damage. E. Activation of excitatory N-methyl-deaspirate NMDA receptors. And if you were listening to our previous slide, you would realize that the correct option in here would be option C, which is the blockade of inhibitory neurotransmitter release in the central nervous system. Let's do some questions. A 47-year-old man presents to the emergency department with 24-hour of progressive weakness, double vision, and difficulty swallowing. These symptoms started approximately 36 hours after he consumed a meal consisting of home-canned green beans, smoked fish, and a store-bought potato salad at a family gathering. Given the suspected diagnosis of botulism, which food item most likely contributed to his condition? The options are home-canned green beans, B. Smoked fish, C. Store-bought potato salad, D. All of the above are equally likely, E. None of the above. If you recall from our slides earlier, you will realize that the home canned products are the most likely to cause botulism if canned inappropriately. Therefore, the correct option is going to be option A.
Okay, now let's try a question. So which of the following statements is true? A. C. difficile is diagnosed through a blood test detecting C. difficile specific antibodies. B. Fecal microbiota transplant, or FMT, is not recommended for patients with recurrent C. difficile. C. C. difficile infection is not associated with antibiotic use. D. Vancomycin and fidaxomicin are preferred antibiotics for treating moderate to severe C. difficile. Or E. Hand sanitizers containing alcohol are effective against C. difficile spores. So the correct answer in this case is D, that vancomycin and fidaxomicin are preferred antibiotics for treating moderate to severe C. difficile, and you may remember this from our earlier discussion of management. If we just run through the other answers though, so A is incorrect in this case because C. difficile is diagnosed through stool sampling, not blood sampling, and we don't look for antibodies, we look for the toxin genes. Fecal microbiota transplant is recommended for people with recurrent C. difficile. C. difficile infection is associated with antibiotics, making C incorrect. And E, the spores are in fact resistant to many hand sanitizers. And so E is incorrect. Okay, let's try a question. So which of the following is a characteristic diagnostic finding for actinomycosis? Our options are positive anti-nuclear antibody test, detection of sulfur granules in the tissue biopsy, presence of acid-fast bacilli on sputum smear, elevated erythrocyte sedimentation rate, or a positive rapid antigen test. So this is not actually something that we covered in our presentation, but maybe something that you are, in fact, tested on in MRCP. So the correct answer here is B, the detection of sulfur or yellow-like granules in the tissue biopsy. If we just run through the other answers, A is incorrect because this infection is not associated with anti-nuclear antibody or ANA. You'll recall from our previous series that ANA is associated with autoimmune conditions such as lupus. If we look at option C, this infection is not associated with acid-fast bacilli on sputum smear. This is more classically associated with tuberculosis. While you may see an elevated ESR, this is not specific to actinomycosis, so D is incorrect. And a positive rapid antigen test is more associated with conditions such as COVID-19, so this is also incorrect.
Thank you for listening to this episode of Bite-Sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear in future. See you in our next episode.